Good afternoon, everyone. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual grand rounds, a surge in silicosis, not just miner's lung. Silicosis is a long recognized occupational disease affecting workers who inhale silica dust, preventable by reducing or eliminating silica dust exposure. In recent decades, however, hundreds of cases have been identified worldwide among a new set of workers. This epidemic has been identified in California as a source of significant morbidity and mortality. In this virtual grand rounds, I'm delighted to be joined by two experts in this disease. Dr. Amy Heinzerling from the Emerging Workplace Hazards Unit of the California Department of Public Health investigates cases of silicosis among California workers, and Dr. Jane Fazio from UCLA Pulmonary and Critical Care Medicine has identified and treated many patients with this disease. Next slide, please. Here are the disclosures of our speakers. Next slide, please. Here is our agenda for the day, and I do want to acknowledge CDPH as our important partner in providing this relevant public health education for the physicians of California. Next slide, please. And here are our learning objectives. Just as a reminder, this series is accredited for CME credit. You'll be sent a survey at the completion of the webinar where you can attest to attendance. And after you complete that survey, we'll send out your certificates. So starting off, I'd like to welcome Dr. Amy Heinzerling, who will be giving us our state epidemiology update today, in addition to our silicosis presentation, as our usual presenter, Dr. Erica Pon, is unavailable this week. Thanks so much for stepping in, Amy. Amy is a MD, an MPH, and a public health medical officer, and the chief of the Emerging Workplace Hazards Unit in the Occupational Health Branch of CDPH. In her role there, she's worked on topics including the 2019 vaping-related lung injury outbreak, infectious diseases such as COVID-19 and Mpox in workplaces, and the growing epidemic of silicosis in workers in California. Go ahead, Amy.
Thanks so much. All right. So I'll be starting off by covering our respiratory virus trends, usually covered by Dr. Pon. Next slide, please. Thank you. So we'll be discussing current trends as well as projections for the coming weeks, and then giving some brief highlights from recent CDPH KHAN advisories. Next slide, please. As an overview of current trends, COVID-19 activity is currently stable. Influenza activity remains low, but we are starting to see it increase. RSV activity is continuing to increase, and we're also seeing some other circulating viruses, most notably enterovirus, rhinovirus, and parainfluenza viruses. Next slide. This slide gives those trends in a bit more detail. To start off with, RSV activity, which you can see in yellow on the right, has been climbing in recent weeks. Influenza activity, shown in dark blue towards the bottom, still low, but also trending upwards. And then COVID-19 activity, which you can see on the right in pink as a percentage of outpatient visits for influenza-like illness. And then on the left, this test positivity has been fairly stable. Next slide, please. Overall, COVID hospital admissions and deaths remain low. Next slide. This slide shows COVID trends in wastewater surveillance across the state. So in most regions, we've seen SARS-CoV-2 concentrations starting to trend upward this past week after plateauing across the state last week. Levels are high in the northern part of the state, including the Rancho and Sacramento regions, and low to medium elsewhere. Next slide, please. ED visits for all three viruses have remained stable. Next slide. Hospital admissions for COVID also remain low and stable across all regions of the state. Next slide. The same goes for deaths due to both COVID and influenza. On the right, you can see COVID deaths, which are shown by the red line, and flu, which is shown in yellow and is low enough to not currently be visible. Next slide. Looking ahead, flu admissions are forecasted to increase in the coming weeks. Next slide. Looking at COVID and flu together, the combined forecast for hospital census is stable, with flu shown in blue at the bottom, making up an increased proportion. Next slide. This slide shows a couple of possible scenarios for hospitalizations for this coming season relative to prior seasons as modeled by CDC. So scenario A, which you can see on the left, would involve moderate flu and RSV seasons and staggered peaks of each virus. So we would see higher levels of hospitalizations than we saw in the 2017-2018 season, mainly due to that added burden of COVID, but still lower than last year's season. Scenario B, shown on the right, which would involve severe influenza and RSV and overlapping peaks, would see hospital admissions roughly matching last year's season. Next slide. Of course, there's a number of uncertainties at this point that will influence these trends, including things like possible new COVID variants, as well as importantly, vaccine uptake for all three viruses. Next slide, please. In terms of vaccine uptake, here are some of the key takeaways for messaging. For RSV, as many of you know, there's a shortage of the RSV monoclonal antibody for infants. And so providers should consult the CDC guidance for help prioritizing doses. As an additional strategy to address that short supply, providers should encourage pregnant people between 32 and 36 weeks gestation to receive the RSV vaccine in order to protect their infants. And then older adults are encouraged to discuss the RSV vaccine with their providers. And as part of this discussion, providers and patients should consider a patient's risk for severe RSV-associated disease. Some risk factors to consider include things like chronic medical conditions, patients who are frail or of more advanced age, and those who reside in nursing homes or long-term care facilities. For flu, everyone 6 months and older should get a dose, and it is safe to vaccinate regardless of egg allergies. For COVID-19, everyone 6 months and older is also encouraged to get a dose of the new vaccine. Next slide, please. In terms of uptake of the latest COVID vaccine, we still have some work to do. So as you can see here, only under 7% of the California population is up to date, meaning that they've received a dose of the most recent COVID vaccine. The percentages, as you can see, go up with increasing age groups, but even among those age 65 and older, less than 20% are currently up to date. Next slide, please. This slide is a reminder about the Bridge Access Program, which helps provide free access to COVID vaccines and treatments to adults who are under or uninsured. Next slide, please. Looking at a particularly high-risk population, residents of nursing homes, as of the end of October, only 8.5% of nursing home residents among reporting California nursing homes had received the updated COVID vaccine this year. Next slide, please. And this is data from a study over the summer that looked at treatment of nursing home residents diagnosed with COVID-19, found that only 1 in 4 nursing home residents diagnosed with COVID-19 had been treated with antiviral treatments. And over 40% of nursing homes reported that they'd never administered any antiviral treatments for COVID. Next slide, please. So now I'm just going to briefly touch on highlights from a few recent CDPH KHAN advisories. KHAN on October 27th addressed RSV season. I've touched on some of this already, but at the time that this came out, we were seeing an early start to the RSV season in California, as we did last year. And then this KHAN also touched on prioritization for a shortage of the RSV monoclonal antibody for infants. Next slide, please. And earlier, Kahan had touched on preparation for respiratory virus season more broadly. In particular, here wanted to highlight the ample supply of COVID therapeutic agents that continue to be underused, particularly among vulnerable populations. So encouraging their use, and also this Kahan contained some reminders about required reporting for respiratory viruses and outbreaks. Next slide, please. Shifting gears a little bit from our respiratory viruses, this Kahan from the end of October addressed the recent case of dengue in California. So the first locally acquired case of dengue in California was detected in a Pasadena resident, and then census advisory was issued. Actually, a second case of locally acquired dengue has also been identified. Next slide, please. And then finally, another Kahan on that same day addressed recent increases that we've been seeing in Mpox cases in California, reminding providers to be on the lookout, test patients with suspected Mpox, and additionally included some data about Mpox among persons already vaccinated for Mpox, and just a reminder that even those who are vaccinated are still at risk, so should be tested if presenting with compatible symptoms. Next slide, please. If you want to get these updates in real time, you can go to the web link here to reach out to sign up for Kahan, to receive Kahan alerts. Next slide, please. And just a few final slides as reminders of resources available for providers. So CDC's COCA calls are available for providers. And just to highlight a few recent ones here addressing RSV and flu, those are all recorded and slides are available online. Next slide, please. Some vaccination resources for a variety of diseases here, linked here. Next slide. Reminder about test to treat for COVID. And so, the COVID antigen tests continue to be available and work on current COVID variants. And so those who are symptomatic are encouraged to test and of course, be treated if diagnosed with COVID. Next slide. A few resources here addressing test to treat. And then next slide. Some additional tools for providers regarding COVID treatment. Next slide. Thanks.
Thank you, Amy. Thanks so much for stepping in on that. Now I would like to introduce Dr. Jane Fazio. Jane's a pulmonary and critical care physician, as I said, at UCLA and its affiliate LA County Hospital, Olive View. She's also working on her doctorate in health policy and management at the Fielding School of Public Health at UCLA. Her primary clinical and research interests include occupational and environmental pulmonary disease among immigrant populations. Specifically, her work centers around policy, advocacy, and research to combat a growing epidemic of silicosis among predominantly Latino immigrant workers in California. And she's an affiliate researcher with the CDPH Occupational Health branch in this work. Thank you so much, Amy and Jane, for being here today. Tell us all about it.
Back to me. I'm going to put my occupational health hat back on here and turn to the topic of the day, just silicosis. So first of all, thank you so much for having us today to discuss this important topic. So today we'll be discussing how silicosis, which as you heard is an ancient disease, has been affecting a new population of workers. We'll be sharing some information about what's driving this epidemic and how California providers can help address it. Next slide, please. So I'm going to start by telling you the story of how this problem first came to our attention in California. So I work in the CDPH Occupational Health branch, and in early 2019, an epidemiologist in our branch was reviewing hospital discharge data as part of our surveillance for occupational respiratory diseases. She came across a 37-year-old man who had been hospitalized with silicosis in 2017. Next slide. Further review of his records revealed that he'd worked in a countertop fabrication shop from 2004 to 2013. And so for a little bit of context, those are shops where large stone slabs are cut down to size and finished and polished before going on to be installed in kitchens and bathrooms as countertops. We'll get into this a bit more shortly, but because most materials used in those countertops contain silica, the cutting and finishing that takes place in those shops can release hazardous levels of silica dust. Next slide, please. So after nearly 10 years of working in this kind of shop, he presented in 2013 to an emergency room with respiratory symptoms and was ultimately diagnosed with silicosis. And then over the next few years, his symptoms and his lung function worsened. Next slide, please. In early 2018, he was referred for lung transplant, but was deemed ineligible. And later that year, at age 38, he died of silicosis. Next slide, please. Before I tell you more about where this led us next, I just want to take a step back to give a bit of context. So silica is one of the main components of Earth's crust, and it's found in many materials, including glass, sand, granite, and quartz. When left undisturbed, it's harmless, but when silica-containing materials are cut or crushed or similarly disturbed, they can release tiny particles of silica dust. Next slide. When inhaled, these particles travel deep into the lungs where they can cause inflammation and scarring and lead to silicosis. Exposure to silica dust is also associated with other health effects, which you'll hear about a bit more later, including lung cancer, mycobacterial infections, autoimmune diseases, and chronic kidney disease. Next slide. Exposure to silica dust almost always occurs in an occupational context, meaning that workers are exposed in their workplace, and it's been a recognized occupational health hazard for centuries. One of the most infamous silica-related occupational incidents happened in the 1930s during construction of the Hawks Nest Tunnel in West Virginia, where thousands of workers who were digging the tunnel were exposed to extremely high levels of silica dust. Hundreds of them died of silicosis in the years following the tunnel's construction. This actually led at the time to congressional attention and to the initiation of a Stop Silicosis campaign by Frances Perkins, who was then the Secretary of Labor under FDR. Despite this, in the decades since, we have continued to see silicosis cases in workers in a number of industries, both in the United States and worldwide. Next slide, please. One such industry is the countertop fabrication industry. So I gave just a quick overview of this industry earlier and why it can be dangerous for workers. But in recent years, there's been a new development that's made it especially dangerous. So any of you who've remodeled your kitchens or shopped for real estate in recent years have most likely heard the term quartz countertops. So this term is used to describe a material known more formally as engineered stone, which is a composite material made of crushed quartz that's bound together with resins, along with pigments and other additives. Next slide, please. Engineered stone has been gaining in popularity due in part to its durability and stain resistance. And since 2007, demand for this material in the United States has increased about 500 to 600%. And it's now the most popular material used for countertops. Next slide. The problem is that while most natural stone materials like marble and granite contain low to moderate levels of silica, engineered stone is made almost entirely of silica. So the workers who cut this material can be exposed to extremely high levels of respirable crystalline silica, along with resins and other pigments that may also be toxic. Next slide. The first cases of silicosis among workers who cut engineered stone came to light first in 2010 in Spain, which perhaps not coincidentally is the headquarters of Cosentino, one of the major engineered stone manufacturers, and then more a couple years later in 2012 in Israel, which is headquarters of Caesarstone, another large manufacturer. Since then, hundreds of more cases have been identified in those two countries, as well as others, including China and Australia. These cases have been especially concerning because many affected workers are young, some with only a few years of work in the industry, suggesting particularly high exposure levels. In the United States, the first case in a countertop worker was reported in Texas in 2015, and since then, over 100 cases have been identified across the country. Next slide, please. Many of those cases are right here in California, where we have been expanding our case finding efforts since we identified that first case back in 2019. We're now at a total of 93 cases and counting. I update this number almost every week among countertop workers in the state, including at least 10 we know of who have died. This graph breaks down the cases by year of diagnosis, where we have that information. And as you can see, cases have been going up over time. Don't be fooled by what looks like a lower number in 2023. Those data are still incomplete, and we expect that that number will continue to increase as we finish our case finding. Continue. Sorry, next slide, please. So we took a closer look at 52 of these cases in a recently published case series, and just want to highlight some of the key demographics of these workers. So all of the affected workers were men, and most were relatively young with a median age of 45 at diagnosis. Almost all were immigrants from Mexico and Central America. We also took a look at insurance status and found that about 20% were uninsured, while close to 40% were covered only by restricted scope Medi-Cal, which can suggest possible undocumented status. Next slide, please. Sorry, there we go. So workplace controls do exist that can help protect workers from silica dust. It's a preventable disease with the right controls. These controls include things like tools with water feeds to suppress dust, local exhaust ventilation systems, and fit-tested respiratory protection, all of which are shown in the photo here. Cal OSHA does have silica regulations that set limits on silica dust exposure for workers and require certain worker protections. But many shops in this industry are not in compliance with those regulations. A recent review of Cal OSHA inspections of countertop shops showed that over 70% of those shops were out of compliance. And interviews with workers have indicated that many workplaces are not using required controls to protect workers from silica dust. With that, I'm going to hand things over to Dr. Fazio.
Thank you, Dr. Heinzerling. So to elucidate details of this disease, we wanted to review a typical case. So we're going to present the case of a 35-year-old Mexican male who presented to the emergency department with progressively worsening shortness of breath and on exertion and dry episodic cough over the last 2 years. Next slide. Here we describe the frequency of symptoms at time of presentation, as was published in our case series that Dr. Heinzerling mentioned, of 52 silicosis patients. The red asterisks correspond to symptoms experienced by the case presented today, indicating he had shortness of breath, cough, and weight loss, and had developed a pneumothorax as well. Although this is a disease where screening in the asymptomatic phase should be done, only 7 patients in our series were asymptomatic at the time of diagnosis. Next slide. Here we see our patient's initial chest radiograph, which clearly is abnormal and demonstrates multifocal consolidation and reticulonodular confluent opacities with associated volume loss, especially on the right side. And consolidated opacities are most prominent in the mid and upper lung zones. And you can also see obliteration of the paratracheal stripes, which may suggest mediastinal lymphadenopathy. Next slide. Here on CT imaging, panel A and B show axial CT images of the first panel A, lung apices, and B, more inferior sections, with the red arrows demonstrating bilateral perilymphatic micronodules, and then panels C and D showing coronal views, with the blue arrows in panel C demonstrating large areas of micronodular conglomeration into very mass-like densities with calcification, and the yellow arrows in panel D denote prominent mediastinal and hilar lymphadenopathy. Next slide. Silicosis classically has 2 stages radiographically. The first is dominated It is known as simple silicosis, which is really dominated by this micronodular pattern, which is demonstrated here again. And then next slide. And when the progression of small nodules progresses into larger than 1 centimeter consolidations, this is termed progressive massive fibrosis or complex silicosis and is considered the advanced stage of disease. In our case series, nearly 40% of patients were diagnosed with progressive massive fibrosis already at the time of initial diagnosis, indicating late access to healthcare. Next slide. Delays in care are common. Likely because silicosis is an uncommon disease, the diagnosis is often missed by the initial treating clinicians in the clinic or the emergency room, which is partially why we're here speaking today. Patients are most commonly mistaken for having bacterial pneumonia or active pulmonary TB, along with other diagnoses such as asthma or sarcoidosis. This misdiagnosis actually has also led to multiple patients receiving unnecessary RIPE therapy for sometimes months prior to establishment of the correct diagnosis. Next slide. In order to prevent delay, we have to suspect the diagnosis. Clinicians should have a heightened index of suspicion in the correct clinical scenario. For instance, when a young Latino male patient who's otherwise healthy presents with respiratory symptoms, either acute or subacute, and or an abnormal chest x-ray, it's critically important to just ask a basic occupational history, such as do you work cutting or fabricating stone countertops, and then subsequently to have a very low threshold to follow up with CT imaging in order to make the diagnosis of silicosis, even in the absence of clear findings on an x-ray. Next slide. A more detailed occupational history for this disease includes not only just occupation and industry, but years worked, relative amount of time exposed to engineered stone during the time that they've been working, and if engineering controls such as the wet cutting methods Dr. Heinzerling mentioned were adequate to decrease silica dust levels, as well as type and frequency of respirator use. There's evidence that anyone who has worked in the industry for more than a few years could be at risk, as some of the cases in our series were worked for as few as 7 years. Median work tenure among participants in this case series was 15 years, with less than half regularly using the wet cutting methods that are kind of the industry standard, with variable respirator use and quantity of use. Nearly half of the workers continued working despite receiving a diagnosis of silicosis. Next slide. In terms of our patient, further history revealed that he had worked as a stone countertop fabricator with engineered stone for 10 years, that he did not have silica dust engineering control measures in his workplace, such as water suppression, local exhaust ventilation, or dust collection systems to reduce aerosolized silica particles. And he didn't have any employer-provided personal protective equipment, which should include a full face mask with bilateral dust-specific filters at minimum. Next slide. This disease is also proving to cause high healthcare utilization, as it's affecting a demographic that is relatively underinsured, as Dr. Heinzerling mentioned, leading to disease commonly being initially diagnosed and treated in the emergency room, as well as the inpatient hospital setting, especially due to the severity of hypoxia and pneumothoraces that tend to develop. Next slide. A quick word on diagnosis, that an occupational history that is consistent with exposure to respirable crystalline silica and characteristic CT imaging is sufficient for diagnosis. However, in some cases where there may be coexisting rheumatologic disease or concern for another underlying infectious etiology, lung biopsy pathology can also be diagnostic and helpful. Biopsy usually is in the form of endobronchial and transbronchial biopsies, but can be done percutaneously as well. Next slide. So clinical next steps once the diagnosis is made. Pulmonary function tests are quite helpful and are a clear next step after diagnosis. Most cases, again, from our case series demonstrated that the majority have restrictive lung disease, but there's also a preponderance of mixed, both restrictive and obstructive disease, which may be useful in terms of understanding the benefits of our long-acting bronchodilators, and inhaled corticosteroids. This is not dissimilar from other early interstitial lung diseases. Of the patients with normal lung disease, many also have only a reduced DLCO, which is common in any early interstitial lung disease. Next slide. I alluded to this earlier. However, there's a well-known connection between silica exposure and development of rheumatologic disease. Therefore, it is imperative to screen patients with silicosis for concomitant disease, both on history and screening autoimmune labs. Silicosis is most associated with rheumatoid arthritis, with one study citing a 3.5 times increased risk of rheumatoid arthritis among silica-exposed persons compared to the general population. But also scleroderma and myositis have been described, as well as lupus. In general, silicosis has been shown to be highly associated with anti-nuclear antibodies, as well as angiotensin-converting enzyme levels, but the clinical significance of this is not completely understood and is one area of active investigation. Next slide. I wanted to provide some images of what silicosis looks like. And here on the left, you can see a gross anatomy image of a lung explant after transplant with progressive massive fibrosis. And then on the right is a histologic image of the same patient. Actually, this is all our patient that we're talking about. And you can see all of the pink areas kind of that are splotchy throughout, which show focal areas of proteinosis at the periphery. Next slide. Showing some other pathological images. Here we can see some of what are known as silicotic nodules, kind of the almost onioning appearance here, which are often seen in transbronchial biopsies as well. They're sometimes not quite as fully formed as this nodule. Next slide. And lastly, for pathology, here we can see dense fibrosis of PMF on the top two slides. And then on the bottom, you can see we're looking at slides with polarized light, and we can see those weakly birefringent silica particles. And so with all of this, we can accurately make a diagnosis of silicosis. Next slide. I wanted to talk a bit about outcomes. Dr. Heinzerling highlighted some of this, but it's important to understand that progression of fibrosis, despite the removal of exposure, is extremely common. When people, even with early disease, remove their exposure, they continue to have declines in lung function. In our case series, we found that the time from diagnosis to death was less than 3.5 years on average, and death occurred at a median of 46 years old. And if you can kind of remember back to the beginning, the average age of diagnosis was 45, and yet the average age of death is 46. So it can often progress quickly. Many patients do require continuous supplemental oxygen. Nearly a quarter of cases have either undergone lung transplantation or have died from their disease. Next slide. On the next few slides, I hope to highlight what it looks like to monitor and treat this disease. So first, disease monitoring includes a functional assessment of PFTs, 6-minute walk, and repeat CT imaging. It's important to highlight as well that silica exposure is a known carcinogen, and although we have clear guidelines for lung cancer screening in smokers, there's not a clear guideline for lung cancer screening in silicosis patients. However, it is in the guidelines to consider occupational history, and so this is a patient population where I would consider screening patients for lung cancer, especially if they already have silicosis. I think we're advancing quickly here, but the next kind of bullet point is to evaluate for concomitant diseases. I spoke briefly about this, but it's important to evaluate and diagnose any rheumatological disease that may be concurrent with silicosis, because as silicosis is not treatable, particularly treatable, many rheumatological diseases are. There are some folks that have both silicosis and also rheumatoid arthritis associated ILD, and so that can be somewhat treatable with immunosuppressants. It's also important to look for infection. We're finding more and more patients and cases with non-tuberculous mycobacterial infections, and not as many as we would have kind of estimated based on prior data of active tuberculosis, but that's still something that we're actively concerned about. In terms of treatment, like I mentioned, there aren't medications that we use with a whole great deal of success, but the most important thing is counseling patients to reduce their exposure, whether it means changing jobs, finding a new job within their same company. And then, as I presented on a prior slide, almost half of patients that are diagnosed with silicosis still continue working, and a lot of that's because they don't have many don't access workers' compensation. It can be a convoluted system to access. And so encouraging your patients who are affected to seek workers' compensation benefits for wage replacement and medical care. And then to refer to your friendly neighborhood pulmonologist who can do things like start antifibrotics, kind of have a better sense of when to refer someone for lung transplant, and then to kind of trial inhalers, which can be sometimes quite effective in terms of symptom management with inhaled corticosteroids and long-acting bronchodilators. And then ultimately, lung transplantation is really the only cure, which doesn't have great outcomes. Median survival is about 6 years. And sometimes some data from coal mining suggests that pneumoconiosis patients may not have as good of outcomes as some age-matched other diseases. So not what we should be doing. I think most of the focus needs to be in the more upstream areas. Next slide. I just wanted to conclude with a message from one of my patients who spoke out recently, both in the Los Angeles Times and in a couple of other spaces, that doing this work, he states, generated a lot of dust. It covered my whole body. I used a mask to reduce the dust and used water cutting tools to reduce the dust from the stone, but the dust was still everywhere, all over me and the shop. I was diagnosed with silicosis. I had to apply for disability and can no longer support my wife and children. A few weeks ago, I was approved to receive a lung transplant and I'm waiting for the call. So this is not the case, the gentleman in the case that I presented earlier. Unfortunately, the gentleman in the case I presented earlier did not make it to lung transplant. This gentleman, however, did and is in recovery. Next slide. I'm going to go ahead and pass it over back to Dr. Heinzerling.
Thank you. So just a couple final thoughts here. The first is that, while as I highlighted earlier, the number of silicosis cases in California has been increasing over the past few years, it's likely that there are even more cases that have not yet come to our attention. These may be workers who have not yet sought medical care, whose diagnosis has not yet been recognized by providers, or whose cases have not been reported to public health. So to try to get a sense of the true scope of the problem, we can take a look at some disease prevalence estimates from other populations. So in one example, when we looked at all current workers in one countertop shop in California who were screened for silicosis, we found that 12.5% of them had silicosis. Looking in Australia, where large screening programs have been offered to all current and former workers in the countertop industry, prevalence rates upwards of 20% have actually been identified. And so we know that there's upwards of 1,000 countertop fabrication shops in California, most with at least a few workers, some many more. And based on these numbers, it's likely that there are hundreds of cases of silicosis among countertop workers that have not yet come to public health attention. Next slide, please. So this is where California providers come in. Though some cases of silicosis, like our index case, have been identified through medical records review, most cases have actually been reported to CDPH by individual providers like Dr. Fazio. Knowing about these cases helps improve our understanding of the scope of this problem in California and helps us direct resources accordingly. In some cases, when we learn more about these cases, especially when there's more than one case in one workplace, this can help facilitate interventions in unsafe workplaces and protect other workers. So please do be on the lookout for these cases. If you suspect silicosis, make sure to, as Dr. Fazio highlighted, ask your patients what they do for work. And if you identify a patient with silicosis, please report it. You can visit the CDPH Occupational Health Branch website for instructions on how to do so. And just wanted to highlight that we're actually currently in the process of making silicosis a reportable condition in California, meaning that case reporting to public health will actually be required as it is for a number of other diseases. And we expect that change to go into effect in early 2024, so stay tuned. I think as we've hopefully convinced you today, we have a lot of work left to do to address this problem and help protect these workers. But California clinicians have a very important role to play by identifying these patients in your practices, by ensuring that they receive timely and appropriate care, and by reporting cases to public health. Next slide, please. If you'd like to learn more, links to a few key resources are here. Particularly recommend checking out our branch website, which has links to all of these resources, including resources for providers as well as for workers and employers. Next slide. Thanks very much, and we're happy to answer any questions.
Thank you so much to the two of you for that incredibly comprehensive telling us that story. So that's so important, and I think most of us didn't know about. I'm glad that we're able to put this forward in this setting. You answered so many of our questions, which was great because it's so comprehensive, but there were some people who were wondering a few more things. One of the questions is just, what is the risk for people in other industries who are doing other types of stonework, flagstone, landscaping, using slate, other types of stone, and using natural stone? Do you have a sense of whether there's de minimis risk or there's still risk, but it's obviously lower than this particular type of work?
I can take this. Yeah, I mean, there's a risk of silica dust exposure when working with any silica containing material. Anything that sort of breaks it apart can generate silica dust that can be inhaled, that can cause silicosis. So there's some risk associated with any of that work. Generally, the more silica in a product, the higher the risk. The higher intensity of exposure, the higher the risk. So there's a lot of different variables at play with this particular population. The reason we're highlighting it is both the fact that we're seeing all these cases, but particularly the very high levels of silica exposure that are happening, likely both due to the material itself having very high levels of silica, as well as just how common and popular it's becoming. And so these workers are just being exposed to it day in and day out at very high levels. That's causing an intensity of exposure that we rarely see in other industries. In other industries, we typically see lower levels of exposure over longer time periods that can ultimately lead to disease, but we're talking about over the course of decades rather than over the course of 5 years.
Yeah, I mean, the rapidity with which this is happening is quite frightening for these young workers and devastating for families. I guess one question that we had was, or that I had specifically, is if you had unlimited resources right now, which of course we never do, how would you go about this? Would you, study more of these factories where the workers are using and really do sort of screening for anyone who's working in this industry, or how would you think about that?
I can take this one. So you kind of asked the $1 million question, and there's a lot actually happening on a lot of different levels that I can just speak about. The kind of most upstream solution is to get rid of the product, right? And so there's a lot of talk already. Australia, as Dr. Heinzling mentioned, is kind of ahead of the game. They have a government-sponsored screening program for anyone that works in this industry, where they're doing X-rays and CT scans for anyone that works in the industry, and they're finding, about a quarter of workers have disease. And they, over the last year, have really gotten their trade unions involved and have made kind of a formal recommendation now to ban the material altogether, and trade unions in Australia are stating if the government doesn't ban the material, then they won't work with it, because they've found it nearly impossible to work with safely in any kind of real world environment. Now, not every country is, poised to do that, and I think here, there are certainly a number of stakeholders, obviously manufacturers being one of them, who would prefer not to have their products banned, right? And so can we find a way to work with materials safely for a reasonable cost? And then can we, do we have the rules in place and then the infrastructure to enforce the regulations? And so Cal OSHA is doing a lot of work to implement a temporary silica standard. So basically update the current silica standard that exists to become more stringent, to essentially ban any dry cutting. And if someone is doing that in their shop, then they the temporary standard as it stands right now, which is not in effect fully, states that they then, if they see that, they'll have the power to basically tell the shop to come into compliance and that they can't continue work until that happens. Among other stipulations. And so I think, Cal OSHA working on the temporary emergency standard to kind of increase the stringency of the regulation, but then also enforcement is necessary as well. And I think, you said, if I had, as much money as possible, I would, do something like Australia has done, where they really have a effective government, screening program where, everyone and anyone who's been exposed to this material can get the really already mandated screening tests, given their exposure history. So I think it's definitely a multi-pronged kind of approach to the solution of the problem. And I think another thing that could be useful is kind of getting businesses that do use this product into kind of a structure where there's some regulation of, who this product can be sold to. Just kind of like we have, with asbestos, we have people that you have to be certified in asbestos removal to do that work. And so do you have to have, some kind of certification in stone fabrication practices to be able to use the material. And so I think these are, again, ideas that are in different stages of progress already around the state of California and Los Angeles County.
Just to add briefly on the screening piece, I think the upstream, prevention is really where our focus should be. But for workers who are already exposed and already affected, we didn't really touch on this in our presentation, but employers are actually required to be providing screening for their workers who are exposed to silica. Most are not doing that. So as providers, if you see patients who work in this industry, even if they're not symptomatic, really they should be screened for silicosis. And that's sort of a limitation of our current system, is that, employers are supposed to be doing it for their workers, but are not. And then, workers who are no longer working in the industry, there's no provision for them to be screened at all. So work to do on that end also.
Right. Well, it certainly illustrates to me the importance of taking an occupational history and a really complete one, which I think sometimes in our fast-paced world gets missed. But say we do, and we find someone as a provider in an office that has been exposed. Can you just be really clear about what exactly is the screening that you would do?
Jane, do you want to take that one?
Yeah, so it depends, right? So screening, the word screening, when you think about public health, is really meant to be a silica medical exam in someone who is asymptomatic. So that would include a physical exam with usually an occupational medicine physician and a chest x-ray and basic spirometry, and a tuberculosis test, given the kind of historical concurrence. I think if someone's coming to you in your clinic with symptoms, then we're sort of out of the realm of screening at this point. We're trying to diagnose. And so starting with a chest radiograph is kind of the first step. But then the buck doesn't stop there if it's normal, because sometimes you can have small micronodular disease that maybe isn't picked up on imaging, or you can have the concomitant pneumonia or something in addition. And so I think that first step is really kind of changing your way of thought, where you think, hey, like maybe I should ask an occupational history, or just even the one question of, what do you do for work? And that might be enough. If they work in stone countertop and they're there with respiratory symptoms, then you really have a high index of suspicion that you should have a high index of suspicion that this is silicosis. And at that point, starting with an X-ray would be fine, and then moving towards a big high resolution imaging and lung function tests, and while referring to a pulmonologist. Anything to add, Angela?
Yeah, that was really helpful. Just on the screening side, say in the public health setting, because Jane, that you said that a chest X-ray often isn't enough. Is a chest X-ray plus the pulmonary function tests enough, or should we be doing CTs as well in that setting on the screening side?
So that's also a question that we're actively looking at. So we're enrolling in a study to actually answer that exact question, because the fact is that we don't know. That stipulation in the Silic standard, using chest X-ray and spirometry, is older, before before low-dose CT was approved for lung cancer screening, for instance. And now that we have low-dose CT kind of at our disposal, we're Dr. Heinzling and I are collaborating on a study that looks at that very question. So our hypothesis is that CT is probably more sensitive as of a screening modality, but we haven't formally answered the question yet.
Some people are wondering about, it sounds like obviously that super high volume exposure to the silica dust is associated with this rapid progression to disease, but the smaller exposures maybe in other industries, but also people are wondering about smaller exposures that might happen as household exposures, like kids and spouses and other family members who are exposed to the dust that comes home in the clothing worn by these workers. Do we have any sense of whether that leads to maybe much longer term disease, but any kind of disease risk at all?
Yeah, I think that's a tough question to answer. I don't think we've really looked carefully at, for example, household members of these workers. It is certainly a concern, people bringing home silica dust on their clothing and exposing family members. We do know that there have been some cases of workers in these facilities who aren't necessarily the ones doing, the cutting, the polishing themselves, but maybe are doing, more office type work in the same building. There have been some silicosis cases even among those workers. So, it doesn't necessarily require that direct, very high intensity exposure. But I don't think anyone's really looked at household members. A related question I would say I get with some frequency is about people who may be exposed when, say you're having new countertops installed in your home, and, the workers come in and they're doing some cutting on site. Is that an exposure of concern? So certainly, we don't want anyone exposed to silica dust, but, that one-time exposure is probably not especially concerning. And then once the product is installed, it's not a risk once it's in your house. But I kind of like to flip that question around and say, well, it's not an exposure. It's not an exposure of concern to you and your household, but certainly it is to the workers who are making the product. And so, when you're thinking about remodeling your kitchen, thinking about what products you're choosing and kind of the whole life cycle of, are these products safe for the workers who are making them?
Right. Just a brief one talking about potential household exposure. Someone was asking about the silica in cat litter and if there's any literature that suggests that people who are frequently changing their cat litter have any potential lung damage because of that.
I haven't seen anything, Dr. Heinzling.
Yeah, that's not one that's come across my radar.
Okay, great.
Yeah.
Just going back to the workplace standards, do we know how effective, if a workplace is using the highest level of standards, is there a sense yet of how effective that is? I mean, as you said, Jane, in Australia, they were thinking of banning it because we just can't prevent this disease. But if folks were really holding to those standards that are now part of the OSHA regulations, would that be helpful? Are there studies about that?
I think the best data comes from the Cal OSHA, who's done all of the workplace investigations, and even since the 2016 standard. And it's hard to tell, it's hard to tell because over almost 3/4 of those investigations had infractions of the silica standard in their law. So of the shops they investigated in 2019, 2020, only 1/4 of them didn't have infractions. And so really a minority of shops are capable of doing these kind of industry standard engineering controls. For a number of reasons. Not, they're extremely expensive, right? The purchase of one of those kind of water saws is extremely expensive for a small business, and so there's a lot of considerations in terms of whether or not it's even feasible to kind of outfit your shop with the industry standard from a small business perspective. So I think to answer your question, I don't think we truly know the answer to that. I don't know if Dr. Heinzerling has anything to add there. Or other data.
And there have been some studies from NIOSH and others looking, going into workplaces, measuring silica dust levels once different kinds of controls are installed. And the takeaway there is that, it really matters how a control is installed. So, they looked at cases where someone was using a water-fed tool, which is kind of one of the main recommendations, and depending on kind of the exact tool and where the water was landing in relation to the work that was happening, they weren't always effective at controlling exposures. And same with ventilation systems. You have to have a ventilation system that's really set up in the right place relative to the work that's happening to really eliminate that exposure. And so to really be sure that your exposure controls are working, you really have to install them and then go in and do exposure monitoring actively to make sure that the levels are low enough, which is not a guarantee. So, for all the reasons that Dr. Fazio highlighted in terms of the engineering controls not being feasible to install, and then, even when they are installed, not always being effective, it's really a challenging problem.
Yeah, just really quickly adding that we're talking a lot about engineering controls, which as a physician, coming into the occupational world, the first thing that you kind of ask is like, you tend to ask your patients is, are you wearing a mask? Are you wearing a respirator? And so I just also want to highlight that, the mask and the respirator is kind of the lowest level of protection available to this worker, and alone is not sufficient in most cases. And so while it's helpful to counsel and advise, about respirator use and quality of respirator, really, the conversation we're having here about engineering controls is because it's way more effective than the individual, wearing the respirator. And we shouldn't be kind of like blaming patients for not wearing the respirator because we know that it's not really sufficient.
I'm really glad you brought that up. That's an excellent point. One of the questions, which is such an important one, is how can we help educate physicians across California about this important issue that seems like, as you say, Amy, that tip of the iceberg thing came to my mind before you brought it up even in a slide, because it feels like there's so many workers who are at risk for already having this disease and certainly getting it over time. So I just want to remind everybody that the recording of this webinar will be available this evening by 5 o'clock, and you can share it with your colleagues and your medical centers and everywhere possible. And some of the resources in these slides are available right now, so you can also send that out to folks. Amy and Jane, any other tips about kind of how to get the word out or how to help you advocate for worker safety in this issue?
I think, we anticipate doing more outreach in association with silicosis becoming a reportable disease. So certainly being on the lookout for that. As I mentioned, our occupational health branch website has a lot of great resources. So please do visit, take a look at those and share them. And we are available and always happy to answer questions and be a resource. So I appreciate the assistance getting the word out.
Well, Drs. Heinzerling and Fazio, this has been so helpful, and it's just such important work. So thank you. That's all the time we have today, but I just want to remind everyone we will receive that survey at 5 p.m. today where you can attest to your attendance. So you'll get your CME certificates in about a week, and the recording will be there. So in December, we will not have a virtual grand round. So we wish you all a happy hippity hoppity hoppity, must be Easter holiday season. And our next session will be Tuesday, January 9th. We'll be discussing the CARE Act, which is a really important and interesting act that help us manage some of our most vulnerable folks in California. So please join us for that, and we look forward to seeing you then.